Hey everyone, welcome to The Explainer. Let's just dive right into this. Today, we are unpacking an absolutely crucial resident case study in hospital medicine. We're looking at a classic, super high-stakes scenario, venous thromboembolism, or VTE. We're going to track a real-time medical emergency, following a patient from the exact moment she presents with a deep vein thrombosis to the terrifying second she develops respiratory symptoms and ultimately a pulmonary embolism. Basically, we're looking at one patient, two linked diagnoses, traveling straight from the calf to the lung. Let's get started. Here is the clinical reasoning roadmap we'll be walking through today. Number 1, the patient's presentation. 2, the anatomy of a blood clot. 3, diagnosing DVT with the Wells criteria. 4, what happens when the clot travels. 5, diagnosing PE using the Wells criteria. And 6, treatment and risk management. Okay, let's jump right in.
Section 1, the patient's presentation, case study. Let's set the scene on the wards.
Picture this. You're the resident on call, and your patient gives you this exact chief complaint. She says, "My right leg is swollen and it hurts to walk." So who are we looking at? Well, our patient is a 62-year-old woman. She is post-op day 5 from a right total knee replacement. You take her vitals, and she's tachycardic with a heart rate of 104, and her oxygen saturation is sitting at a really concerning 93% on room air. Now, what's really fascinating and frankly terrifying is the escalating history of her present illness. You map out the timeline and it goes like this. 5 days ago, she had major orthopedic surgery. Fast forward to 2 days ago, and her calf starts feeling kind of tight and full. By this morning, the entire leg was swollen and warm. But the real alarm bell, that's what happened just 1 hour ago. Sudden, sharp, right-sided chest pain that gets way worse when she breathes, along with acute breathlessness. You see what happened? A localized leg problem literally just became a life-threatening chest emergency right in front of us. Section 2, Anatomy of a Blood Clot, Pathophysiology. To really grasp what's happening to our patient, we have to look under the hood at the underlying pathophysiology. First things first, let's get our definitions straight. Venous thromboembolism, or VTE, is an umbrella term. It covers, well, any clot in the venous system. So that includes both deep vein thrombosis and pulmonary embolism. The absolutely crucial takeaway here is this. We are fundamentally talking about one single disease process. It's just happening in 2 different places in the body. Now, location matters immensely when we're talking about a DVT. If you have a distal DVT, meaning it's located way down in the calf veins below the knee, well, that's one thing. But a proximal DVT, one that's located higher up in the iliac, femoral, or popliteal veins, that is a much bigger threat. Proximal clots carry a massively higher risk of breaking off, causing a PE, and ultimately leading to death. Let's trace the actual literal journey of this thrombus. Think of it as the embolic pathway. Step 1. Driven by post-op immobility and venous stasis, the clot forms in a leg vein. Step 2. It propagates proximally, kind of just growing up into those larger femoral or popliteal veins. Step 3 is where it gets bad. A piece breaks free, embolizes, and shoots up through the right side of the heart. And step 4, it lodges violently into a pulmonary artery in the lung, putting huge strain on the right ventricle and completely tanking her blood oxygen. Section 3, Diagnosing DVT, Wells criteria. Let's see how this pathophysiology translates into our diagnostic approach for that initial leg swelling. When you're standing at the bedside examining that leg, you are hunting for classic signs. You're looking for a calf that is more than 3 centimeters larger than the other one, venous distension, warmth, tenderness, maybe some pitting edema. And our patient, she has almost all of these. But hey, here is a really surprising fact for your clinical practice. Do not rely on Homan's sign. You know that calf pain on dorsiflexion you memorize in medical school? Yeah, it's actually present in less than 5% of DVT cases. The truth is, no single physical sign can definitively rule a DVT in or out. Because our clinical gut feelings can be a bit vague, we need something totally objective. Enter the modified Wells score for DVT. This system is great. It assigns exactly 1 point for specific clinical features, things like major surgery, localized tenderness, or a significantly swollen calf. And if you think another diagnosis is just as likely, you subtract 2 points. This whole thing beautifully turns our subjective bedside exam into hard, undeniable math. So let's apply this math to our 62-year-old post-op patient. We just add up our points. Recent major surgery, that gives her 1 point. Localized tenderness, another point. Entire leg swollen, 1 point. Calf 4 centimeters larger, 1 point. Pitting edema, 1 point. Add all that up and her exact score is a 5. Since any score of 3 or higher mathematically places a patient in the high pretest probability tier, We are virtually certain she has a DVT in that right leg.
Section 4. When the clot travels, embolization. All right, buckle up because the clinical stakes are about to escalate rapidly.
Remember that sudden chest pain and shortness of breath our patient developed an hour ago? Those are the absolute classic manifestations of a pulmonary embolism. To put that into perspective, about half of all PE patients will have dyspnea, and roughly 40% are going to get that sharp pleuritic chest pain. On exam, you might also hear a loud pulmonic component of the second heart sound, that's your loud P2, and you'll see tachycardia, exactly like our patient's heart rate of 104. Basically, the clot has officially hit her lungs.
Section 5. Diagnosing PE Wells criteria. We know she had a DVT. Now we need to formally score her for the second half of this linked diagnosis.
Now, notice how the PE Wells score is a totally different beast compared to the DVT one. It is heavily weighted. Not all symptoms are created equal here. Just look at the very top of the list. Simply having clinical signs of a DVT instantly buys you 3 full points. Why? Because as we established earlier, VTE is one disease. If you can see the clot in their leg and they suddenly have chest symptoms, they almost certainly have a clot in their lung.
Let's calculate our patient's PE score. She gets 3 points right off the bat for her blatant DVT signs. Her elevated heart rate of 104, that gives her another 1.5 points. And her recent knee surgery, which was less than 4 weeks ago, gives her another 1.5. Add that up and her PE score is a definitive 6. So what do we actually do with a score of 6? We look at this simplified interpretation. If a patient's score is 4 or less, a PE is considered unlikely, and you can totally just start with a simple D-dimer blood test. But any score over 4 means a PE is likely. Our patient's score of 6 dictates that we entirely bypass the D-dimer test. Seriously, a D-dimer won't help us here at all. She needs to go straight to the scanner for CT pulmonary angiography to confirm the PE.
Section 6. Treatment and risk management. Next steps. Okay, we've traced the disease, we've scored the probability, we've confirmed the diagnosis. Now, let's fix the problem. The protocols give us 3 main buckets for initial anticoagulants. You've got low molecular weight heparin, like enoxaparin. That's great for patients with cancer or during pregnancy. Then there's unfractionated heparin, which is really reserved for complex cases, renal failure, hemodynamically unstable patients, or if you're actively planning thrombolysis. But our patient, well, despite her hypoxia and tachycardia, her blood pressure is actually stable. Because she's stable, a direct oral anticoagulant, or a DOAC, like apixaban, is absolutely the right choice here. It's highly effective, and it's going to make outpatient care down the line so much easier.
The next logical question is, how long do we keep her on this treatment? Well, because her clot was provoked, actually, let me be specific, because it was directly caused by a major temporary risk factor, which was her orthopedic surgery, she falls perfectly into the standard 3 to 6 month treatment window. Once she hits that mark, she can be reassessed to see if we can safely stop the anticoagulation. Before we wrap this up, let's lock in these 5 key takeaways. These are essentially resident mantras. 1. VTE is one disease in 2 places. 2. Always score before you scan using the Wells criteria. 3. Match the test to the probability. Please don't order a D-dimer if the clinical probability is already high. 4. Getting the diagnosis is only half the job. You have to risk stratify your patient. And 5. Treat the current clot, but then make sure you prevent the next one. Which brings us to one final provocative thought. Sure, we successfully treated this patient's emergency today, but if this entire crisis was clearly provoked by her knee surgery, what crucial thromboprophylaxis step was missed when she was discharged on post-op day 2? Think about it. The reality is she was sent home without any pharmacologic clot prevention, and that really drives home the most vital lesson of all. The absolute best treatment for venous thromboembolism is preventing it from forming in the very first place. Keep that in mind on your next rotation. Thanks for hanging out with me for this explainer, and keep learning.